Welcome to today's webinar. It is my pleasure to introduce today's speaker, Dr. David Rudd, who has had an amazing career, which includes titles like clinician, researcher, professor, diplomat, and even university president. If you'd like to know more, he has a great Wikipedia page you can check out. Dr. Rudd is also well known for his groundbreaking work in suicide prevention, and I know he's going to illuminate some key insights for us today that should enhance the care we provide to those around us. So, Dr. Rudd, thank you so much for your time. The floor is yours.
Oh, thanks, John. Yeah, absolutely. Good to be with you. I'm going to talk to you about shame, stigma, and how it relates to suicide. And for people that are clinicians, I'm going to share with you just a way to think about this problem and to share this in your narrative with people that you work with around suicide. And understand that a large part of effective treatment and effective assessment is about getting people engaged, building therapeutic alliance, and building trust as a part of the process. Understanding the dynamic of shame and stigma is at the heart of that difficulty. And so this applies really broadly to what people bring in when you see somebody at risk. And so you see a slide there that 47% of Americans believe that seeking therapy is a sign of weakness. And the reason I share that is half of half of the population that you see will walk into the door thinking that this is a sign of weakness. This is evidence of individual failure, individual defectiveness, regardless of what you do. And what's surprising about that is that very few clinicians actually respond to that data. So very few people talk about that. So it's important to recognize that is always a part of the undercurrent of the clinical interaction, is this belief about individual weakness just because they're engaged in therapy. So I'm going to encourage you to develop and shape a model for what it means to be human, and always share that as a part of the intervention for suicide risk. And what it does is it undercuts this reality that people believe there's individual defectiveness and weakness because they're having thoughts about killing themselves. That's a huge part of effective care, is just this model and perspective. Understand that this is actually even more significant for veterans and for males relative to females. It's about 75% of veterans, which are 92% of veterans are male versus female, believe that getting therapy is a sign of weakness. And what I would suggest is you ought to always address this in the clinical interaction. It ought to always be a part of what you talk about why somebody thinks they're there to see you. And a big part of it really is understanding shame, and understanding the distinction between shame and guilt. Shame is identity based, and so shame is if there's something wrong with me, versus guilt, which is the idea of I did something wrong. And so I'm going to talk to you a little bit more about that and about differentiating that for people and helping people understand that. But recognize that shame is this notion that there's something wrong with me individually, that I've done something wrong, I'm a defective in some way, I'm a failure in some way. And when you look at suicide as an issue, a lot of risk is intertwined with individual identity in terms of how people see themselves. And that's why framing therapy is really important. That's why framing treatment, why are you here? What are we going to do here? How are we going to work to be effective is really critical. In creating this counter argument is essential. So when you think about shame, I would encourage you to think about shame as really about who we are as an individual, and it carries this belief that somehow someone is inherently flawed, damaged, worthless, or defective. And it is the foundation of what we call is one of the factors that elevate risk, is this idea that I'm unlovable, that regardless of what I do, people won't care about me because I'm flawed, damaged, worthless, and defective. And so I would encourage you that regardless of what brings somebody in, this ought to always be talked about. And the way to do it is to develop a model of what it means to be human and explain to somebody, help them understand why they're at elevated risk, why they've had thoughts about suicide, why they've made a suicide attempt, from a perspective of what that means to be human. And I'm going to share that a little bit more specifically for you in just a bit. The idea of guilt is distinctive. Guilt is tied to what is tied to our behavior. It's about what we've done. And what I would encourage you, we help people make a differentiation between learned guilt and earned guilt. So it's the idea of, for most people, they learn to label a feeling of dysphoria, distress, and upset as guilt. And we learn that early in life in our early relationships. So when you talk with people about adverse childhood experiences, difficult family environments, exposure to trauma, exposure to violence, oftentimes we learn guilt in those experiences because the adults that are involved in those early experiences actually blame the child. So when somebody's a victim of abuse, somebody actually experiences violence as a child, oftentimes it's labeled by the adult in that way. So think about that as a part of it. Those are always linked to suicide risk. The problem is we don't talk about that enough with people directly. We talk about symptoms like depression and anxiety, but not about how you think about who you are as an individual and how that's related to your risk. So these things are all intertwined. So when you think about shame, stigma, they're tied to these ideas of dishonor and this idea that something is wrong with me. And as the slide there indicates, the vast majority of pain that drives and individual suffering that drives the idea of suicide and suicide motivation really is identity related. Too frequently, we tie it to other things like day-to-day problems, certain kinds of experiences, in terms of stressors in people's lives, and we don't connect that identity piece. And if you don't connect that identity piece, it makes it more difficult to have enduring impact when you actually intervene. And I'm going to talk to you a little bit about the model is one of those. Now, here is an example, and I share this. This is an actual suicide note from a young man who died. This was a young college student who shot himself and was having difficulty, was depressed, and was anxious. But a part of why I share this note is to explain this dynamic of shame and identity. And if you read that note, he says, "The hate that rages within me rages not for those I love so dearly or those who have crossed my path. It rages full force towards me and only me. I've long forgiven those who've hurt me, but I have not and cannot come to terms to forgive myself for the things I've done and the things I've done to hurt those in my life." That's exactly the construct I'm talking with you about, is this idea of shame and stigma and this perception that somehow there's something wrong with him and this idea of learned guilt about his behavior. And the problem that he was having is he wasn't performing well in college. He wasn't doing well in school. And rather than recognizing it was a function of a major depressive disorder and an anxiety disorder, his model for understanding his behavior is that he was defective, flawed, and unlovable, couldn't recover, tragically, there was not opportunity for treatment and intervention, and he killed himself. And this core piece of identity, I would argue, is always a part of the challenge. And so I'm going to really encourage you to think about this idea of suicidal ambivalence and to recognize that it's tied this there is always a coexistence of a will to live and a desire to die. This will to live and desire to die always coexist. And what's really important for people is to define it and operationalize it. That when somebody comes in to see you, it's really important to help people recognize and understand that a part of them wants to live and a part of them wants to die. And the reason it's important to define that ambivalence and to help people recognize it is then you can mobilize the ambivalence in the direction of living. But if you don't recognize that those two things coexist, when you interact with people, when you look at the research around this issue, people feel like you're dismissing their suffering and pain. But if you can define the ambivalence, acknowledge the presence of it, and then talk to somebody very clearly about, we're going to work on your wish to live, your will to live. We're going to do interventions around that, and we're going to move it in the direction of living versus the direction of dying. So you acknowledge the presence of these ambivalent forces in both directions. You define it, operationalize it, and then we target it very specifically clinically. The first place you target ambivalence is by giving them a model for understanding why they're suffering and why they're hurting. And that model ought to include that this is normal part of human existence. This is what it means to be human. And that you've misunderstood that. And that's a part of this idea of unlovability, this idea of shame and stigma, and the idea that it's not weakness, failure, and personal flaw that is at the heart of the problem. So I'm going to give you a model for that. And in addition to that, I'm going to talk to you a little bit about where this comes from. Why do people have this perspective? And it is embedded in Western culture. That a part of the problem is this really is embedded in terms of Western culture. Now, when you think about ambivalence, and again, you'll get a copy of these slides, I would encourage you to understand that ambivalence is a part of every time we think about changing our behavior, we need to be ambivalent. So that's why it's so critical to create ambivalence, to define it, and then you do things that move it in a certain direction. The first thing that moves it in the direction of living is providing a model that says this is not unusual given your life circumstances. This is not unusual for you to be suffering and hurting given the life circumstances, given your life experiences. This is not unusual. That relieves some of that pain and suffering. It creates ambivalence, creates the opportunity to actually move people in the direction of living. This is the slide is a model of behavior change that is from a academic and a clinician. His last name is Prochaska, and it's Prochaska's stages of change. And what he says is before you can ever prepare and engage in activities, I'm going to share some stuff at the very end, you have to be ambivalent. So you have to feel ambivalence in order to move in that direction. The reason that it's important to acknowledge that ambivalence, define it for people, is they won't feel ambivalent if they feel you've dismissed their suffering. And hopefully that makes sense, that if you've dismissed their suffering and haven't explained their suffering, they won't fully engage, they won't feel ambivalent, they won't have this recognition that a part of them wants to live and a part of them wants to die. And what we're going to focus on clinically is the part of you that wants to live. That's really the critical piece here. Without that ambivalence, Prochaska and what the research would say about behavior change is you'll never get meaningful behavior change. Every clinical trial that we've done, we get very significant behavioral change because we use this model. And so I would encourage you to understand that. And that model is embedded in this idea of shame and stigma and in addressing it directly, regardless of what kind of therapeutic model you use. Now, one of the things I would encourage you to think about is when people ask for help, it's a very complicated thing. So one of the things that happens is we tend to underestimate how complicated this actually is. It requires a lot of things when somebody comes in to ask for help. So when somebody comes in to ask for help, part of the reason people feel that it's a sign of weakness and difficulty is because they don't really understand the landscape for clinical care. And nobody really explains to them how difficult treatment and clinical interaction can be. So think about this for a second. If you're going to ask for help, it really requires you to have these different elements. You need to be emotionally aware of your own risk. You need to be motivated for care. You have to acknowledge vulnerability, acknowledge that you can't manage it alone. You have to be willing to engage in emotional intimacy with somebody that you don't know. All of those things are really tough. And in particular, they're tough for people who are thinking about killing themselves. And I would encourage you, the list is even longer. You have to be able to verbalize and communicate your emotional distress. Most people who are struggling don't have the emotional awareness and capacity at that moment to do it. You have to trust others in this context, despite probably a history of relationships that demonstrated people aren't trustworthy. And when you trust somebody, you get hurt. And that's really difficult. You have to overcome all of these tough lessons that life has taught you, and you have to do it at this critical moment when you're ambivalent about living and dying. And what I would encourage you is one of the first steps you and I ought to do with everyone is when they come in, is we ought to say, it is really difficult to be here, and I understand that and recognize it. And here are some reasons why it's really tough. And these are the very things we're going to help you work on. And everyone has that kind of difficulty when they ask a stranger for help. And so part of what fuels this idea that I'm flawed, defective, and weak is that people don't understand why they're having difficulty when they sit down with somebody. They're struggling to share with somebody. They're struggling to be honest with somebody. They're struggling to share personal details with a stranger. And all too often, clinicians don't explain that this is normal, this is natural, this is a part of what it means to be human. If you do that, you undercut this idea in a very significant way, and it creates an attachment and a bond that really is the foundation for progress in clinical care. And that really is essential. So I would encourage you to think about that, explain that to people. And if you need any evidence of that on the slide, this is one of the call boxes from the Golden Gate Bridge. These were an enormous failure for over 4 decades. And only recently did they net the bridge in recognition of that failure. The suicide rate from the bridge has been dramatically high for since 1937 when the bridge opened. The suicide rate had gone up every year. And these call boxes were put on 3, 4 decades ago, never worked. And the reason they didn't work is on this previous slide, all of the reasons I just pointed out. But why did we put the call boxes up? The call boxes were put up to say that we did something. And that not only did we do something, but we did something that was highly ineffective. And so I would encourage you, when you think about suicidal ambivalence and you think about this problem and you think about intervening around shame and stigma and helping people recognize and understand this idea of what does it mean to be human as a part of your model and perspective. Always think about John Baldwin. He jumped off the bridge, and when he was interviewed, he's one of the few people, just a handful of people to survive this. Mr. Baldwin said, I instantly realized that everything in my life that was unfixable was totally fixable, except for having just jumped. The time for him to think about that is before he gets over the rail. And that's the very thing that targeting ambivalence, targeting this idea of wish to live, wish to die, explaining why it's tough to engage, and then providing a model of being human creates an attachment that allows you to do clinical interventions that undermine that kind of a problem and this kind of a tragedy. It's a great example of ambivalence. So let me talk to you just for a minute here about what does it mean to be human? Why do we have a hard time thinking about this just from our perspective? So I would tell you that just the daily contradictions that all of us are raised with is at the heart of the problem. And it starts with how we think about pain and about suffering. So when you think about physical pain, all of us understand that physical pain is a normal part of life, and that if you feel physical pain, it's a signal that something is wrong. And it's a signal that we've been hurt in some way. So you think about if you've had a headache, if you've had a toothache, you know that it's a signal you need to respond to. And so it's integrated into our perspective of normal physical functioning, even to the point to where we recognize and understand that physical pain is a part of actually building strength and stamina. So everybody's heard the phrase no pain, no gain. And that in order to build toughness, in order to build resilience, tolerance, and stamina, you're going to have to deal with some physical struggles and some physical suffering and difficulty. It is absolutely not that way when we think about emotional suffering. For some reason, we don't mirror that model on the other side, even though emotional health is not dramatically different than physical health, and the two are incredibly intertwined in terms of being human. So I would encourage you that at the heart of this, that when you provide a model, that it's really nice to provide a model to help people understand the way you think about your physical life is the way we ought to start thinking about your emotional life. And we ought to start understanding that a part of building emotional resilience, emotional stamina as a human is a part of understanding we're going to have emotional pain. And we're going to have negative emotional experience in our lives we need to learn and grow from. That creates a foundation that's not tied to this idea of I'm weak, I'm broken, I'm ineffective. And it's tied to the notion that everybody has this challenge. And if we want to be resilient, we want to build emotional stamina, we're going to have to deal with emotional pain. So these things are really in sharp contrast. If you look at physical pain, you can just go pick up a book that talks about this. But on the emotional side, that's not the case. And what's tragic about it is on the physical side, this is undeniably accepted. I bet if you went and surveyed 10 people today, 10 people will tell you, absolutely, I'm not going to build physical stamina, physical strength unless I struggle. And this idea that I've got in the slide there for you, that suffering pays the path to victory. We never think about it that way on the emotional side. On the emotional side, we are very vague. We are very general. We don't like to talk about negative emotional experiences, and we've pathologized it. So if you look at the theories that explain emotional pain and emotional suffering, they talk about individual weakness, individual defectiveness, the very things we started with. So I would tell you that as a profession in psychology, psychiatry, mental health counseling, this is a big failure. This is arguably one of our most significant failures, is the pathologizing of normal emotional experiences and emotional pain is individual weakness and defectiveness, to the point to where most people don't understand. And if you actually talk to people about defining guilt, defining anger, sadness, joy, jealousy, fear, anxiety, they're not able to define those things independent of saying there's something wrong with me. So a big part of treating this problem is understanding and defining these elements. And I would really encourage you to think about that. This ought to be a part of what you do with everybody, regardless of what your theoretical model is for psychotherapy. And I would tell you that guilt is a good thing. Now, if it's learned guilt, then it can be inaccurate and inappropriately assigned. If it's earned because of your behavior, the reason we experience the guilt is because it helps manage our behavior. It's a part of empathy. It's a part of actually connecting to people and understanding that who we are and what we do affects more than just us. All of those are critical things. Now, on the slide that I shared with you there, if you want to look at theories, overwhelmingly, we have pathologized emotional suffering. And at the bottom are some different psychologists, psychiatrists that have had theories about this problem, Baumeister, Schneidman, Sandler, Bolger, Orbach, and others that say this is a sign of inadequacy and being psychologically broken. And I would encourage you, that's not the case at all. That there's not a single human being that has not had emotional pain and suffering that's related to relationships and life. And that we ought to understand, recognize that. And a part of building resilience is how you deal with that and how you process, understand, and integrate it. And understand that that doesn't mean there's something wrong with you, it means you're human. Helping somebody who's thinking about killing themselves recognize and understand that diffuses shame and stigma. And I will tell you, and if you would like scientific evidence of this in terms of our clinical trials, I'll share it with you. We have had consistently profound impact when we intervene this way at reducing suicide risk dramatically and consistently across all kinds of clinical contexts, because it is tied to identity. Regardless of what the other problem is, it's going to be tied to identity. And you ought to always uniformly intervene in this way. So I would argue that it really is critical to define this as a normal part of human functioning, talk about these different emotional elements, understand and recognize the distortion in how people understand, define them, and ultimately integrate them, that's a huge part of this problem. If you want some examples that are ridiculously relevant in terms of day-to-day life, you can just pick up a thesaurus and look at the synonyms for strong: tough, tenacious, capable, steady, secure, sturdy, rugged, vigorous, and look at the synonyms for sensitive: careful, delicate, thoughtful, emotional, nervous, unstable, and susceptible, which is remarkable. And that is just simply in the thesaurus. And I would tell you that's not the appropriate definition of sensitive. That's where this stuff is born, is in this foundation of what we've developed and understood over the years. So that if you pull up Merriam-Webster, this is literally out of the dictionary of Merriam-Webster in terms of the definition of sensitive: easily hurt or damaged, delicately aware of the attitudes and feelings of others, and then if you look at the bottom, abnormally susceptible. The dictionary pathologizes the problem. So if you wonder where this comes from, it comes from daily interaction. And what I would tell you is you redefine the term sensitive. And I would tell you the very thing where we started about when you engage, what's hard about asking for help is this stuff. This is what somebody has in their head when they're asked, why are you in therapy? Because I'm defective. And it's born in our simple definitions and understandings of emotional experiences and the poorly defined models that we have for emotional pain and emotional suffering, and how is that related to being a normal human being. And so I would encourage you, a big part of your intervention ought to be defining this. If you ask me what's an appropriate definition of sensitive, I would tell you it's being aware of your own emotional experiences and those of others. That's a better definition than this. It's a more accurate definition than this. And what are the strengths of being sensitive? Is that you have better relationships, better bonds and attachments, deeper relationships, and you know what? They're rewarding and reciprocal, and they last longer. That's an enormous strength. And I can't tell you, when you talk with people about that, the impact that it has. It really is remarkable. Trauma is even worse. So when we talk about lifetime experiences for people, we don't use the word trauma. We talk about exposure to violence, because that's really what it normally is. It's violent, usually in some form or fashion. And if you look at the definition, this is actually the definition of Merriam-Webster. The definition of trauma is a disordered psychic or behavioral state. So the definition is pathologized again. And I would encourage you, if you want to use the word, define it in a way that doesn't pathologize it. Trauma is a normal part of life. And I would argue probably every human over the course of their life is going to experience a traumatic incident in some way, shape, or form. But it ought not be defined that somehow that your response to it is disorderly from a psychic perspective. That's not appropriate. Trauma is harsh and difficult, but it's a part of our emotional experience, and every human has those experiences. And so again, at the heart of this is providing a model. We use the word violence, and we do because violent exposure to violence is humans have a normal reaction to violence, and I've got it on a slide there. Every human has the same response to violence. It varies in intensity based on your nervous system. So based on whether you're introverted, extroverted, and your autonomic nervous system is significantly aroused or under aroused, given your personality and your nervous system foundation for that, you'll have a different magnitude of response, but everybody has this response. So like when we work with soldiers, we talk about everybody is symptomatic when you go to combat. Everybody. You just have different magnitudes of it based on how your nervous system works. And your nervous system is based on your biology, and that's a part of being human. And all of this undercuts and undermines those original ideas about shame and stigma. The reason I share this is because the net outcome of this is that people don't come to treatment. So the median delay between the onset of symptoms nationally in this country is 11 years. And if you look at the slide, it's across every domain of mental health care. People don't come into care because of this very problem. So if you want to keep somebody in care, you want to lay the foundation for good treatment, you explain this model of what it means to be human. You talk about physical versus emotional suffering, why we don't understand it well, help them understand that this is something that's been cultivated in our culture and misunderstood in our culture for generations. And let's come up with a more accurate model. And let's talk about that it's really tough and difficult to ask for assistance and help. And those are enormously significant signs of strength and courage, contrary to what we have come to think over the years. That helps you, along with defining ambivalence, that a party wants to live, a party wants to die. Both of those things lay a foundation for care, regardless of the model of care that we use. Both of those create ambivalence that create the opportunity for behavior change that really is essential to understanding this problem. This gets lost in clinical care all too often, and really is problematic. So I would encourage you to think about that and think about this idea of ambivalence is at the heart of clinical intervention, regardless of what psychological theory you use or perspective you use to treat suicide risk. This is at the heart of it. And I would actually encourage you that even if you're not treating suicide risk, this ought to be a foundation of what we do with everybody, period. That every time you interact with somebody clinically, we ought to talk about what's your model for being human. Let's talk about how you understand emotional suffering. and about what we're going to do here to address emotional suffering from the perspective that this is a normal part of human existence and a part of dealing with it effectively and growing as a person is understanding it accurately, integrating it in a way that is accurate and in a way that recognizes the strength and courage that it takes to do it, and the stamina and resilience it builds. That all of that really is at the heart of this. So I would encourage you to recognize and understand this and understand ambivalence is essential. Your model creates the opportunity to generate ambivalence that creates the window for intervention that really becomes critical. And if you're interested, again, it's about defining the ambivalence is a big part of this. We track ambivalence over time. So we do simple things to track wish to live. We just get people to rate it on a scale of 1 to 10. I would tell you that if you get them to rate wish to live at the beginning of an assessment, you do a model, you talk about the things that we just covered and address and ask them to rate it again at the end, you'll see a significant movement in wish to live, that every interaction that you do, every intervention that you do actually will move ambivalence in the direction of living. And that's what the purpose is. That's why we have significant behavior change. And we do the same thing on wish to die in terms of tracking. But I wanted to get to this slide. I'd be happy to share with anyone that looks at the webinar and goes through it. Every single intervention we do comes from the foundation of creating this model of what it means to be human, undermining shame and stigma, creating this foundation, generating ambivalence, and then we have a series of interventions that take a much longer training. It would take us a couple hours to go through these, but you can read about it. I'd be happy to send you material to read about. Here are things that you can do that move ambivalence for suicidal people very specifically, given the foundation that you've laid. And I think more importantly, I would encourage you that foundation ought to include really any interaction. I mean, I would tell you the first task, the first couple of tasks that we ought to do with everybody that we see is we ought to explain why it's difficult for them to be there. We ought to give them models for being human, and we ought to tell them that because it's difficult, you're going to be ambivalent, whether they're thinking about dying or not, whether they're just depressed or anxious or whatever the issue is. Everyone is ambivalent about clinical care. So this model can be used uniformly regardless of the nature of care that you're doing. So happy to send you more material. Happy to explain in more detail on the suicide stuff that you can do some additional reading. I'll send you that material by email if you'd like. My email address is mdrudd, so mdrudd@memphis.edu. Send me a note and I'll send you some stuff and respond to questions if you would like. John, I think that's it.
Dr. Rudd, that was amazing. I hope we can have you back to unpack pieces on this slide as well. And I'd love your approach of a real humanistic approach to care. I think we all resonate with, and it is the right place to begin. So thank you for that reminder and lesson. Everyone, that concludes our webinar for today. But again, I will try to have Dr. Rudd back again. Thank you so much for your time.
Hey, absolutely, John. Really enjoyed it. And if you ever want to have me back to talk about college athletics, happy to do that as well.
Yeah. Before the webinar began, I got to pick Dr. Rudd's brain about NIL, and I learned a lot. And maybe part of why we're in the situation we're in. So for another time, thank you, Dr. Rudd.
Thanks. You guys take care. Nicole, really good to see you. You guys have a good one and enjoy your holiday.